Welcome everyone, and thank you for joining us. My name is Tanya Long. I'm Senior Manager, National Education of Osteoporosis Canada, and I'm very pleased to be your moderator today. Each Bone Matters Take Charge of Your Bone Health presentation is led by a Canadian expert in osteoporosis to help participants better understand how to prevent the next fracture and how to live well with osteoporosis. Bone Matters is an ongoing series of live and archived presentations. Today we are delighted to welcome our guest speaker, Dr. Stephanie Atkinson. As you've heard from your doctor and from Osteoporosis Canada, vitamin D is a very important nutrient for bone health. But why do we need it? Join Dr. Atkinson today for a presentation all about vitamin D, how much we need and how we can obtain it, how to determine how much our bodies have, and also does the new Canada's Food Guide provide good nutrition for bone health. This presentation will provide you with an understanding of the role of vitamin D in supporting bone and overall health. Now, to submit a question, on the panel on the right side of your screen, you will see a box that says Questions. Type in your question in the text box, and we will receive your question to ask at the end of the presentation. You may submit a question at any time during the presentation, and it will be addressed during the question and answer period if time permits. If not, we will answer after the presentation, so please be sure to include your email address in the body of your question. Otherwise, we will be unable to send the answer. Dr. Stephanie Atkinson is a member of the Scientific Advisory Council of Osteoporosis Canada, a professor in the Department of Pediatrics at McMaster University, and special professional staff in McMaster's Children's Hospital. She serves in a number of leadership roles related to maternal, infant, child, and youth health. Her areas of specialty are nutrition and bone metabolism, and environmental factors in early life as determinants of non-communicable diseases in adulthood, diseases such as diabetes, heart disease, and osteoporosis. Welcome, Dr. Atkinson.
Thank you very much, Tanya. It's a pleasure to be here today. As Tanya said, the emphasis of my talk is on vitamin D. It's a nutrient that's near and dear to my heart, and I hope I'll be able to answer all the questions that Tanya put forward. As many of you are aware, if you read the newspaper or listen to the news, there's been information overload on vitamin D in the past, probably 10 years. And what it's led to is many, what I like to call D-Lemmas of D. And so it's some of those dilemmas that I hope to resolve for you today. So we've been seeing press such as this, that millions of Americans take vitamin D. Most should just stop. And another one, not too long ago in February, D is for discouraging. The celebrity supplement may be losing its luster. All very sensational headlines in various media that can cause us to worry if we don't understand what's behind them. This was another one that was related. Vitamin D supplements aren't living up to their hype, but if you look carefully at the byline under it, it says recent studies say taking extra amounts of vitamin D may not be a boon for everyone. So what is that extra amount? Is that something that we're all taking on a regular basis? Is that pharmacological doses? Is it, it doesn't define it. And the other factor that you have to look at in this picture is they're talking about vitamin D not in relation to bone health, which is the focus of our discussion today, but its association with other diseases and disorders such as cancer, asthma, healthy heart, blood pressure. And there is some new information that's coming forward slowly about vitamin D's role other than with bones, but a lot of that information isn't for certain yet, and then that just serves to muddle the true information about vitamin D and bone health. So we need to focus today on the functions of vitamin D in humans as it relates to our bone. And one of them is that it is the primary regulator of how much calcium we absorb from our intestine and how much calcium we reabsorb when it's filtered through the kidney. And these two sources together are what keep our bones mineralized. So we do have to have vitamin D. We need it to bring calcium into our body. We need it to prevent it from escaping in large quantities through our urine. And that together will help us have healthy bones. So let's just focus on vitamin D today and in what my view is on the current knowledge. And to do that, I propose that we address 6 vitamin D dilemmas. Why and when do we need it? How much do we need? How do we know we're getting enough? Are Canadians at risk of deficiency? Does the new Canada's Food Guide ensure enough vitamin D? And finally, address some of the recent headlines that relates high-dose vitamin D, for whether it protects against fractures. So first of all, D-Lemma 1, why and when do we need it? Well, I have to just insert a little bit of pediatrics here because it's important to know that osteoporosis risk may start within the womb. An area I do my own research in is looking at the importance of the diet of the mother, including vitamin D, calcium, and protein during pregnancy in setting a good start to skeletal development. And so that the mother's environment may influence the skeletal formation of her infant. And then, of course, as babies grow into little children and into youth, they need the appropriate nutrition and exercise and environmental factors that can promote optimal skeletal development. And it's been predicted that when adolescents reach their peak bone mass, which they do at the end of their teenage years, that it's the stronger that or higher that their peak bone mass is, the lower their fracture risk would be. So that really emphasizes the importance of a good start to life on later bone health. And this diagram just reinforces this. You see here from 0 to 20 years of age, a rapid rise in bone in males and females, but it plateaus off early in the late teens and by early 20. And then we need to maintain our bone during our adult years, excuse me, until the time that women hit menopause and men start to lose bone as well. And then we are into the phase of a critical bone loss period, but still need excuse me, vitamin D and calcium. So the answer to when we need it is it's throughout our lifespan. So how much do we need and where does it come from? Well, this is a simple diagram, but it reminds us that if we get enough sun exposure, we probably wouldn't need dietary vitamin D at all, because we have a product in our skin called 7-dehydrocholesterol that, when acted upon by UV radiation, forms vitamin D or cholecalciferol. The problem is we wear clothes, so we don't get full exposure all the time. We wear SPF sun protection because of the concern about sun exposure and skin cancer. We stay inside houses and buildings a lot of the time, and the sun rays don't penetrate the glass. And, you know, some of us have darker skin than others, and the pigment in the skin competes with the UV photons. So the darker your skin, the less efficient you are at making vitamin D. So it turns out we can't count on the sun totally in our society, and so we count on foods. And unfortunately, there aren't many naturally rich foods in vitamin D, so our country fortifies some products, and we'll come back to discussing that. But whether it comes from sun, through our skin, or from foods, or from supplements, all the vitamin D ends up as vitamin D3, which we use and take to our liver and form a compound called 25-hydroxyvitamin D. And this is what we measure our vitamin D status with. So we can do a blood measure to measure how much of the 25-hydroxyvitamin D is circulating in our blood, which will reflect how much sun exposure and how much dietary intake we've had. So using that kind of information, our governments reviewed the literature, both our Health Canada and the National Academy of Sciences in the US. They collaborated on developing dietary reference intakes. That's what we call the recommendations for nutrients. And based on careful analysis of scientific studies, they set amounts of all nutrients that are appropriate for a general healthy population. It's to note that these are not guidelines for people who have exceptional intakes because they have malabsorptive diseases or may have osteoporosis or other diseases. So in a nutshell, the recommendation for vitamin D intake is 600 international units per day up until the age of 70, and then 800 over the age of 70. And this is due, higher amount is due to greater variability in the needs of older persons. The DRIs also set an upper level of 3,000 for younger children and 4,000 for all adults. What is an upper level? Well, it's defined as an amount above which long-term intake might cause some adverse health effects. And it's based on the observations that if chronic high consumption of vitamin D is associated with high blood calcium or hypercalcemia, and it's caused by the excess 25-hydroxy-D stimulating bone loss. So this is a conservative estimate of what the upper amount is. It wouldn't hurt taking a higher amount for short term, but if one was to ingest higher amounts for months and years, you can get into problems such as hypercalcemia. Now, one other aspect that's been a dilemma in the recommendations is while we have our Health Canada recommendations, there are other groups who've had different recommendations, and this can obviously lead to confusion. So the Endocrine Society in the US had recommendations, Osteoporosis Canada has recommendations, both about from 20 years ago, and they're a little bit higher than the ones for the DRIs set by Health Canada. But you'll notice that the upper amount of the range is still less than the upper level recommended by Health Canada. So the difference of opinion here is probably related to the fact that the Endocrine Society and Osteoporosis Canada are looking through the lens of osteoporosis or bone disease as opposed to just the general health of a population, and so have made them a little bit higher. I don't think this is a concerning factor because, as I said, the amount of intake is still well below the upper level of Health Canada. There is another group who did a lot of advertising in the newspapers and recommended even higher intakes, and these I think should be disregarded. So just to recap, the Health Canada guidelines are for general healthy population. The Osteoporosis Canada and the Endocrine Society are based on looking at it through osteoporosis lens. So dilemma number 3, how do we know we're getting enough? What do we assess? What are normal values? Who to assess? And is it easy to assess? So the what to assess, I'm sure you can all answer, because I've emphasized a few times that it's this 25-hydroxy-D that measures our vitamin D status. The more we take in through our diet, the higher this 25-hydroxy-D will be. Our skin synthesis does protect us. Even if you do extensive amount of sunbathing all year round, you'll never become toxic from that, because we have metabolic policemen, if you will, in our body that stop us from producing too much D3. But the more we eat, whether it's food or supplement, we will just keep increasing this circulating 25-hydroxy-D. So what defines an optimal or adequate vitamin D status measured by 25-hydroxy-D? Well, the Institute of Medicine, the Health Canada recommendation is that we should achieve a level of 50 or higher. The worrying low value is 30 or less. This would relate to severe deficiency. And in the middle, it's maybe insufficiency, but it's not usually related to an immediate bone disease. Again, there are other normal values causing confusion. So in the bright yellow are the values defining deficient, insufficient, adequate, and excess for the Health Canada DRI recommendations. And then we see others. The US Endocrine Society recommends higher than 75, and many clinical laboratories, including my own hospital, will say more than 75 or 80. So that has caused a lot of confusion, and I can't give you an answer as to whether that over 75 is actually healthier or not. What has happened is, because of all the interest in vitamin D coming through the press and concern, more people have been requesting that they have their blood tested for vitamin D. And if you look at the statistics from our Ontario Health Technology Advisory Committee, which is the backbone to OHIP in Ontario, they had a huge increase from 30,000 tests in 2004 to over 730,000 in 2009, which increased the cost from $7 to $66 million on just our whole OHIP alone. So they took that under scrutiny and came out with recommendations in 2010 that OHIP would no longer pay for routine vitamin D testing in the general population, and felt that the onus was on Health Canada, Public Health, to advise people about how much vitamin D to take through foods and supplementation, and not having to request measurements of their vitamin D status. However, they were very reasonable in, this is OHIP, and I know this is true for some of the other provinces, that they will pay for testing if you have certain conditions that may put you at risk if you had a low vitamin D status. And this includes osteoporosis, rickets, malabsorption syndromes, kidney disease, or drugs that affect vitamin D metabolism. We're not the only ones in Canada who've gone crazy over vitamin D. There's a real indulgence in the USA as well, and I was able to find information from the same time period, 2000 to 2010, where the dollars spent by Medicare in the US, and vitamin D testing rose 87-fold. And supplement sales in the US skyrocketed from $248 million in 2008 to $1 billion in 2018. So this is one of the reasons that vitamin D has been in the press so much, because people have really been on the vitamin D bandwagon. So the answer to dilemma number 3, is status easily measured? Absolutely. However, it may not be necessary for most people unless they're uncertain of their intake or at risk of deficiency. And we have to be mindful that it's costly, and if it's not clinically indicated, we may be wasting healthcare dollars. So on to dilemma number 4. Are Canadians at risk of vitamin D deficiency? Is that all that extra testing really warranted? Well, fortunately, Health Canada and Stats Canada have, since the early 2000s, been surveying both our health status in general and in terms of dietary intake, and also taking blood samples from a sampling of the population across the country to measure our status for a number of elements, including vitamin D. So the next few slides will share with you some of those results. So overall, this shows the vitamin D status. This is the percent of people who were deficient is in blue, sufficient in red, and adequate in, or sufficient in, excuse me, in green. And you'll see that in the 12 to 19 year group, there was just 8% who were deficient, 20 to 59 years, 12%, and 60 to 79 years, the lowest at 6%. But what they went on to look at was the factors that influence vitamin D status. So as I said, the Canadian Nutrition and Health Surveys look at a number of factors. They look at diet, they look at the demographics of the population. And in a paper by Brooks et al., they presented the factors that they found associated with the better vitamin D status. And that was the number of servings of milk a day, the number of fatty fish a day, supplement use, the amount of sun exposure, the amount of sunscreen use, and for the subject characteristics, the age and sex. You just saw a difference across the age groups for vitamin D deficiency. Whether they were white or non-white, it was associated with their serum cholesterol and their body mass index, which is an indicator of adiposity. So let me show you some of the data that back up these findings. So here's the information on milk consumption improving vitamin D status. Now, just to remind you, in Canada, vitamin D must be fortified in cow's milk and margarine. It can be added to non-cow's milk drinks, but it's not mandated by law. The red line shows that 50 nanomole per liter recommended vitamin D status. And while the mean value for all these groups by different ages is above the 50, you will see that those in the dark blue who had milk more than once a day are always higher than the ones in the light blue, which had milk less than once a day. So showing that drinking fortified vitamin D milk does improve your vitamin D status. Now, if we look at supplements and sun, this graph is the 25-hydroxy D value in the serum. This is winter values, spring, summer, and fall. And if you just look at the black line first, these are people who took, look at the hatch line first. These are people who did not take supplements. So they're below 50 in winter, but by spring and summer and fall, their values are up above 50. if they took supplements, they're never deficient, even in winter, and they go higher. So they have about an 11 nanomole gain on those who don't take supplements. And they did note that supplement use, like we saw for the US, has risen from 2004 to 2015, especially in those older than 31 years. So people are being more cognizant of the need for vitamin D supplements, especially in the wintertime. What about the issue of population diversity? So they divided our population by white and other. So it's just white and non-white. Obviously, the degree of pigment in the skin would be different in terms of efficiency of synthesis of vitamin D, but this was just a simple categorization of white and non-white. And you'll see the green bar is for sufficient, over than 50, and it's 70% of the population of white persons had sufficient vitamin D, 6% had deficient, and 21% insufficient. Whereas the non-white, it was only about 40% who were sufficient, 20% were deficient. So this clearly shows that there is a greater efficiency of vitamin D synthesis from exposure to sun by white skin. The other factor was adiposity. This shows data for overweight and obese children, which unfortunately represent 31% of our country's children. Again, it's the green bars that are sufficient, over 50 nanomoles, and you will see that as we go from normal weight to overweight to obese, the percentage of children who are sufficient status declines. The same can be observed in adults. So this is BMI being the relative body mass. So it's the roughly equivalent to a higher amount of body fat. As it goes from 20 up to 40, there's a decline in vitamin D status in whites and non-whites, but as I said before, non-whites have lower values. The thinking here is that the more adipose we have, the more our vitamin D, which is stored in our fat cells because it's a fat-soluble vitamin, is sequestered in the fat and can't be released. So the answer to dilemma number 4 is of who is at risk of suboptimal vitamin D status. It clearly varies by ethnicity, diet, and lifestyle. So those with low sun exposure have skin pigmentation, full coverage clothing, live, work, and play indoors would be at higher risk. Non-milk and non-fish eaters, non-supplement users in winter, those who are obese, and I didn't show you the data, but breastfed infants without supplements, and I'm going to come to that in a minute. So in summary, what have we learned from these excellent nutrition surveys that Health Canada and Stats Canada have done over the last decade or so? In, the adequate serum vitamin 25-hydroxy D being greater than 50 nanomoles per liter, being associated with a level sufficient for healthy bones for most people. It would appear that almost 70% of all Canadians and most children meet that goal. So we don't have rampant vitamin D deficiency in the country, but we do have groups that are at risk. And these, as I already highlighted, are the non-Caucasians, the non-supplement users, those who have more adipose. It's a bigger problem in the winter, and those who are not milk and fish consumers. So turning to dilemma number 5, does the new Canada Food Guide provide enough vitamin D? I don't know if all of you have had a chance to look at it. I'd encourage you to do so. But it looks very different than the old one, so we just focus on this side. In the old Canada's Food Guide, we had food groups, and we were supposed to pick certain number of servings from each food group. Now it's a food plate, and you see all the different items that we're to include in our diet. If you look on the right-hand side, I've just listed a few of the foods that are natural in vitamin D, such as salmon, and it's a fatty fish, and egg yolk, and then those that are fortified, such as milk, and sometimes cereal, but we also have orange juice and other foods. Can you see these foods in the food plate? Well, you have to look very carefully, but I think that's milk. This is a wee piece of salmon, and there's a quarter of an egg there. So those foods are listed, but they're not in a separate group. So maybe will be a little more difficult for people to identify. I did a little mathematical exercise and pulled out the protein foods from Canada's Food Guide that have vitamin D, so lower fat milk or a fortified soy drink, egg, fatty fish, and orange juice or cereal. And if I assume you took 2 glasses of milk a day or 2 of a fortified soy drink and had 1 egg and 1 fortified something else, whether it's juice or cereal, you would add up to about 300 international units of vitamin D a day. If it was a day you had fatty fish and had a couple of ounces, that could be around 400, so that would get you up to 700. But remember, the DRI is 600 to 800, so it is really difficult if you're just choosing the smaller amounts of these foods, or even lower amounts, to reach that DRI from food alone. Health Canada recognizes this, and in February last year, they put out a proposal that they will increase the amount of vitamin D that will be allowed to be fortified in milk. They realize that it's challenging for Canadians to consume the recommended amounts through the current food supply. So their goal is to double the vitamin D in cow and goat milk and margarine. They will allow vitamin D fortification of yogurt and fortified plant-based beverages that will be equal to milk. And later on, will allow other foods to be fortified in vitamin D. So I don't think this is all going to be rolled out this year, and it may take till next year, but we will have the opportunity to get more of our vitamin D from foods in Canada in the hopefully not too distant future. So what's the overall current status? I think the issues are well documented with respect to vitamin D and risk in our group, in our country. We know who the target groups are. We need to focus on helping them through education and food sources and guidance on safe vitamin D supplementation. I won't repeat the list. They're the same ones I've mentioned already. We know that we're going to have improved vitamin D availability in the food supply through our federal regulatory, and we just need to work on implementation strategies in the community. The one thing I want to emphasize, again, I'm bringing you my pediatric focus, is that we still have vitamin D deficiency of rickets in children, and to me this is a national travesty. There was a pediatric surveillance program done in early 2000s across all the country of pediatricians, and they identified 104 cases of rickets that had been confirmed by X-ray, and 75% of these children were vitamin D deficient, and the mean age was only 1.4 years. In 14-15, they did not as detailed a survey, but still a survey And there were 149 cases of rickets, 48 confirmed by X-ray, and 70% of these children were vitamin D deficient. 50% were less than 9 years, but 50% were older than 9 years. This should not be happening in our country, where we have vitamin D fortified milk, and we have supplements, and we have sunshine. And unfortunately, it is the risk groups again who are most affected. About a quarter were First Nations, Indigenous peoples, and a third were Black children. Most were breastfed, if you're looking at the infants, and they were breastfed without supplements of vitamin D. And yet that's highly recommended by the Dietitians of Canada, the Canadian Pediatric Society. So we have to get the messages out better that we need to protect our children from vitamin D deficiency, because rickets should not be happening in a developed country like ours. It is treatable and mostly curable, but this should not happen. So to prevent rickets in kids, we need to start in pregnancy, ensure that mothers have dietary sources and vitamin D supplements, which are present in most all prenatal supplements, that when babies are breastfed, even with a little bit of formula, they need vitamin D drops of 400 international units a day. And for toddlers and children, if they can get the vitamin D fortified milk, but they can also get vitamin D and calcium fortified soya or other plant beverages if they're not tolerant to milk, or they should be supplemented. Okay, on to the last dilemma. Does high-dose vitamin D protect against fractures? So now we're focusing on the adults, and as we get on in life, we talked about, we start losing bone, and we don't want to lose so much bone that our bones become fragile and our risk of fracture. And Osteoporosis Canada, I've already quoted them. They have guidelines for what they think are the best protection against osteoporosis and fractures. Good dietary sources of calcium with fortified foods if necessary. Be careful about supplements. Don't take high-dose supplements. We've already talked about the vitamin D, and also promoting exercise and falls prevention. But here was a news flash of a few months ago, a systematic review, which is a synthesis of all the studies that are available that addressed vitamin D supplements and fracture risk in adults. It was a study, a systematic review that was published by Boland et al. In Lancet Diabetes and Endocrinology. And it was, as I said, focusing on fractures, falls, and bone mineral density in response to vitamin D supplementation. And the bottom line of their analysis was there was no effect of vitamin D supplements greater than 800 international units a day on risk of fracture or falls, and no difference in bone mineral density by DEXA. But I want to point out the cautious interpretation that one should have of these data. Firstly, they were done in a healthy community of women only, over 65. The intervention was always vitamin D of 800, more than 800 international units a day, sometimes with calcium, some without. The study was, the other limitation is the study subjects. Some were going into the study vitamin D deficient, and some were vitamin D replete. So obviously, if you're deficient, it's going to take you much longer to have a response, and you're going to be more at risk than somebody who's vitamin D replete going in. So I think this isn't the final answer. I also point out that their vitamin D intakes for their intervention were more than 800. So one could interpret this as, so 800 is fine, And that's what the current DRI recommends. And that more than that doesn't help. We don't have the final answer on this, but just to be a little controversial, that could be one interpretation. These results, of course, do not apply to older age people living in nursing homes who have a diet low in calcium and vitamin D, who have less sun exposure and mobility, and who have osteoporosis. As always, Osteoporosis Canada responsibly responded to this study and just reiterated their current recommendations that persons with osteoporosis take 800 to 2,000 of vitamin D a day and achieve a normal 25-hydroxy-D and calcium homeostasis. That there is more research needed to know if we could be more definitive about the optimal dose for osteoporosis prevention or risk of fracture. And the other thing they point out is we must be careful to avoid excess vitamin D because we know it does come with some harms, and I addressed that earlier in my talk. So, what approaches to ensure optimal vitamin D status in Canadians? Obviously, focusing on keeping your 25-hydroxy-D status above 50, and the way to do that is going to become easier, but in the meantime, when we don't have the higher fortification of milk and margarine, that maybe make extra efforts to be sure that you have some of the fortified products that are available, in addition to those like fatty fish and milk. And have judicious use of supplements. And I put this particular picture up because it shows a variety of different supplements. And really these days, the marketplace is burgeoning with different kinds of vitamin D supplements. You can get vitamin D3. If you don't like animal products, you can get D2, which comes from non-animal. You can have it as fish oil. You can find vitamin D that is vegan. You can find organic. You can find gluten-free. And even the way you take it as a capsule, a drop, a liquid, it could be flavored, many different flavors, including chocolate I've seen, and chewable. So if you want to take a D supplement, I'm sure you can find one that's just right for you, because we have no end of variety in the marketplace today. So that concludes my comments of vitamin D and bone health, but also I hope I put in perspective that there's more than just the vitamin D from foods. We have to think about safe sun. And we know another important component of good bone health is exercise. And we need to combine all these factors in our life to ensure that we start out with healthy bones from infancy on up through adolescence. And that might give us stronger bones to face the ultimate consequences of losing our bone mass later on in our years. And that, my friend, is the end of the D-Lemmas. And I'm happy to take any questions, and thank you for listening.
Okay, thank you very much. And let's move right into the question and answer portion of our session. And it looks like we do have some questions.
All right. So we have a number of questions. As a reminder to everyone who submitted them, if we are unable to answer your question today or during this presentation, we do have your email, so we will respond to you. So our first question is, what impact would a 10-year span of bulimia from 15 to 25 years of age have on osteoporosis in later life?
I'm sorry, I can't, you're very broken up. I can't understand what you're saying.
Oh, my apologies, sorry. The question is, what impact would a 10-year span of bulimia from 15 to 25 years of age How can osteoporosis in later age?
Okay, so I can't quote you data on that, but we do know that when there's estrogen withdrawal with bulimia or anorexia, you do lose bone mass. It would depend, you said 15 and up. Now, if the 15-year-old was a female who had achieved almost her peak bone mass, that wouldn't be as harmful as if anorexia started when they're 10 or 11, when the peak bone mass hasn't been achieved. So having 10 years with estrogen withdrawal is definitely going to reduce your bone mass, and how much you could replete after that, I don't know of any data that have followed such subjects longitudinally that would have that answer.
Okay, thank you very much. So the next question is, are there other elements such as magnesium needed in the diet or for supplementation for the body to absorb and utilize vitamin D efficiently?
There are other elements so just talk about absorption of vitamin D. It is best absorbed with other fat in the diet. So, if you're drinking milk and it's 1% or 2% fat, we think that it would be absorbed better than if it's from skim milk, for instance. So if you're taking a supplement of vitamin D, have it with, after a meal so that you've got fat. It's a fat-soluble vitamin, so it gets incorporated into the same micelle that fat droplets are. In terms of other nutrients, I think maybe the confusion is for magnesium, for example, it's a cofactor in converting the parent compound vitamin D to 25-hydroxy-D in the liver. It doesn't affect absorption. So magnesium is part of bone. It's important to vitamin D metabolism, but we probably get plenty of magnesium in our diet if you're, especially if you're eating animal sources. Other vitamins other nutrients that are important to bone but aren't directly affecting vitamin D are things like vitamin K.
Okay. All right. So our next question is, I've heard you can administer your whole week's worth of vitamin D once weekly. Would this be a concern if that weekly amount surpasses the upper tolerable limit that you mentioned in your presentation?
Oh, that's a really excellent question. There are many studies done where they give a high dose once a week, sometimes even once a month, and it's usually in situations where adherence isn't good or it's being handed out in a underdeveloped country, and you will absorb a large amount of vitamin D, and it won't be immediately toxic, that's for sure. The toxicity comes over a long time. It's probably not as effective as daily doses of vitamin D, but in situations where adherence is a problem, in other words, people won't follow taking it once a day, there isn't really a downside to it, except that yeah, I mean, the only downside is it's probably not as effective on a day-to-day basis, but you won't get toxicity by taking it just once a month.
Okay, thank you. So our next question is, what do you think of liquid vitamin D drops versus capsules or tablets in terms of absorbability?
That's another really good question, and I don't think there's been too many studies done on that. As I say, when we take the vitamin D, whichever form it's in, into our intestine, it will be dissolved and incorporated into lipid droplets. So I honestly can't think of a study that's looked at the difference between a caplet and a gel cap and a hard tablet. But I wouldn't think there'd be a huge difference in the absorbability.
Okay, all right. So our next question is, can you talk about the importance of vitamin K2 in the absorption of vitamin D3?
They're absorbed by the same mechanism. They're both fat-soluble vitamins. So they would just be in the same lipid droplet. One's not going to interfere with the other unless, there's one is taken in, a huge overwhelming dose. But I don't think that there's any, side effect of vitamin D on vitamin K or vice versa in the absorption process.
Okay. Our next question asks, I recently reduced my vitamin D total from 2,000 international units to 1,000 international units as a result of reading a study warning about the falls risk from too much vitamin D. What are your thoughts?
Sorry, Tanya, I couldn't understand the last part of it.
Okay, I'll repeat the question. I recently reduced my vitamin D total from 2,000 international units to 1,000 international units as a result of reading a study warning about falls risk from too much vitamin D. What are your thoughts?
Okay, so I think 2,000 is still within the safe upper limit. Remember I said that the upper limit set by the Health Canada is 4,000. I am aware of the studies that have shown high vitamin D intake, but I think it's well in excess of 4,000. So I don't think there should be a difference between 2,000 and 1,000 in relation to falls.
Okay. Our next question asks, what impact does a daily proton pump inhibitor have on vitamin D, if any?
Probably not on vitamin D.
Okay. Just going through, we have a number of questions here. Oh, here's another question regarding large amounts of vitamin D. Why would someone be prescribed 50,000 international units of vitamin D3 per week? And how long can someone take this amount safely?
Well, I've heard of this happening and I really don't understand why. I think it's maybe physicians or whoever the practitioner is recommending them that has some belief that very large doses are protective against, there's a lot of other disorders vitamin D has been associated with other than bone health. But I would not see any reason to have that amount of vitamin D unless you had been diagnosed with severe osteoporosis or rickets and you were vitamin D deficient and you were trying to quickly get the person replete. Otherwise, I see no indication for such high doses.
Can I just interrupt? It's Tanya here. I have heard more frequently about D2 being given in very large doses. Does that make a difference?
No. Biologically, D2 and D3 are probably not too different. The studies have been inconsistent. We think, I think the latest is D3 is maybe more biologically active. That's the one we synthesize in our skin and the one that's naturally in foods. D2 comes from animal sources. But, there would be equal harm and equal efficiency of those two isomers. I mean, it's not going to be a huge difference. So I don't, D2, I think we have a hard time finding it in Canada because it's mostly used in the United States. Most of our supplements and definitely our milk is D3. And it would just be if someone didn't want to have an animal source of D3 that I think D2 would make sense.
Thank you.
Okay, another question that came up is there a different amount of vitamin D that's needed after a hip fracture?
After a fracture?
Hip fracture in particular.
Yeah. Well, there isn't. That's what one of the last slides was referring to for Osteoporosis Canada. Said we don't know the optimal dose of vitamin D post fracture. It just hasn't been studied well enough. I mean, I'd certainly, if you had a fracture, a fragility fracture, that you would, maybe that's an indication to have your vitamin D status measured, and then be sure you're getting, a reasonable amount of vitamin D. I'll give you a personal thing. I fractured my wrist. It wasn't fragility, but I started taking 4,000 just because I wanted to be sure that all the calcium I had was going into that little fracture in my bone. But we don't have any data that would tell us you need X amount more to heal a fracture.
Okay. One more question that came up is asking about your suggestion to use vitamin D supplements judiciously. Could you comment a little bit more about that?
Well, I'm just really referring to not taking excessive amounts over that 4,000 upper level for long periods of time. And hopefully when Health Canada starts this increased fortification, we won't have to rely on supplements as well. It's an extra cost. It's an extra thing to remember to do. And it would be nice if we could get more of it from our food supply.
Okay. This will be the last question that we'll be able to take today. Again, a reminder to everyone who submitted your questions. We do have your email addresses that you submitted along with your questions, and we will reply to those after the presentation. So the last one that we have is cashew milk an appropriate source of calcium and vitamin D?
Is what?
Cashew milk.
Oh, so any nut milk or plant milk, you need to look at the label, because they are allowed to fortify, but not all of them do. So I've seen almond milks without any fortification. It has to be on the label if they're fortified. Most soy milks are fortified, but you really need to be, because there would not be any natural calcium and vitamin D in cashews. So it's up to the company whether they fortify or not. And the new guidelines from Health Canada, as I understand it, they will be allowed to fortify up to the same amount as cow's milk. So if it's your preference to have that source of protein, as long as you find one that's done the fortification, would be okay. But yeah, they've got to be fortified, because they don't, the nuts and soy do not have any natural calcium or vitamin D.
Okay, on behalf of Osteoporosis Canada, thank you, Dr. Atkinson, for today's presentation. Your expertise will no doubt have answered many of the participants' questions about the importance of vitamin D for bone health. Let us know what you thought of the presentation by filling out the evaluation survey. You can access the survey via the link that will be sent to you in a post-presentation email or via the Osteoporosis Canada website. So how can you find out about upcoming Bone Matters presentations? Notices will be published on the Osteoporosis Canada website, news and events, and through our social media feeds on Facebook and Twitter. Better yet, sign up for COPN, that's C-O-P-N, the Canadian Osteoporosis Patient Network. All COPN members are alerted to future Bone Matters presentations, and also to archived presentations once they are up and ready. If you're not already a member of COPN, you can sign up for a free membership at osteoporosis.ca/COPN, C-O-P-N. And a special thank you for everyone for coming today and for participating with your good questions. Thank you.